Evening, everybody, and thank you for having me. And I just want to express my thanks to the Medical Society for the grant for my elective, because without it, it really wouldn't have happened, or it might have happened, but I might have had to walk or something. But so anyway, my name's Alex. I'm final year medical student at Hull York Medical School, and I'm just going to briefly tell you about my elective in Uganda, which was spent at Kisiizi Hospital, which I think some of you may be familiar with from previous elective talks. It seems to be a popular haunt. It's not working. Let me try it. There we go. Okay, so just a little bit about Kisiizi Hospital. Kisiizi Hospital is a not-for-profit mission hospital located in southwest Uganda, right on the border with Rwanda and with the Democratic Republic of the Congo. It's right up in the mountains, and the nearest town is about an hour and a half drive over a mountain. The nearest town is a town called Kabali, which some of you may know. And it serves approximately 300,000 people over a huge area. Some people will travel days and days to visit the hospital. And common causes for admission are malaria, tuberculosis, malnutrition, complications of HIV, and to be honest, most commonly motorbike accidents, especially during the rainy season. And it runs a really, really innovative insurance scheme, which means that the only people who can join this insurance scheme, which enables them to have completely free healthcare, are groups of people. So that might be villages, local churches, local mosques, local farming organizations. And this enables groups to be able to have free healthcare, and you don't just have to be sort of the rich person in the village to be able to gain some healthcare. You can you could be the farmer of the owner of the farm, and that would enable you to have healthcare. Okay, so I just thought I'd present to you some cases which I saw in Kisiizi. So my first patient was a 45-year-old male with known HIV on long-term antiretroviral, and he presented 3 years ago with weight loss, drenching night sweats, and cough. And obviously he was diagnosed clinically with TB, started on the classic right anti-TB medication. And unfortunately, due to long-term follow-up, he did not complete his course of anti-TB medication. Today, he presented with cough, weight loss, drenching night sweats, and dysphagia. He also defaulted on his antiretrovirals. So sort of a hotbed for infection at this point. And on examination, there was crackles bilaterally in the lung fields, non-tender lumps on the left cervical chain. Here's a photograph. I did ask him for the photograph. He was more than happy for me to show people back in the UK. And if anyone can see, I won't get you, if anyone wants to shout out what they can see. If not, it's fine. But what you might be able to see here is what is historically known as scrofula, or cervical tuberculosis lymphadenitis. Now, you know, if you look in your history books from the Victorian era, scrofula was really ripe in the workhouses and in the slums of London, and so it was really interesting to see that still in 2022. And fortunately, we were able to start this gentleman back on his medication. The fungal infection around his face also resolved, and he made a good recovery. This is my case 2. This is a young infant who presented after her mother gave birth in the community. She hadn't received any antenatal care. If you see on the left-hand side, you can see what might be called characteristic rocker bottom feet. Now, obviously I hid the face of the patient, but if there was, you would be able to see microcephaly. There was also cleft palate. Under the nappy, there is micropenis, and also this baby had a protrusion of the abdominal organs. The sharper-eyed of you may have also seen that this child has 6 toes on each foot. and if you have worked out the diagnosis, that was Edwards syndrome. So we saw this baby. He was a sick yet pale-looking infant with low set ears, polydactyly, rocker bottom heels. He also had a really loud yet undefined cardiac murmur. And actually, the presentation of the patient was because he couldn't abduct his arm because the pectoralis major tendon was inserted right at the bottom of the humerus, which meant that the arm was sort of cramped right into the body of the boy. Fortunately, Kisiizi Hospital has a really excellent neonatal department and rehabilitation department. So this baby was able to stay free of charge with mother in the rehabilitation. And as far as when I left, the baby was making good progress. However, we know that Edwards syndrome doesn't have a great prognosis. Okay, and finally, I'm just going to tell you about a scenario that I was in, which was really eye-opening for me. It's given me some things to think about coming back in terms of how I, in my head, triage patients when you see them. And I just thought it was an interesting one to share with you. So the A&E of Kisiizi Hospital has 3 beds. There's 1 doctor and 1 medical student, who was me. Currently managing an 18-year-old female who just turned up with polydipsia, polyuria, dehydration. We took a blood test, turned out there was, urinalysis showed ++ ketones, and we commenced management for DKA. As we were rehydrating her and fixing the patient on insulin, 3 men sort of stumble into A&E, all covered in blood. No one really knows what's going on. I thought someone might have been attacked or stabbed. And the first young man comes in and his face is really quite damaged. And he removes his cap and he shows this large head wound on his head. And sort of putting pieces together, you realize that, okay, there's been a motorbike accident, or as we call a boda accident in Uganda. And there was clear fluid coming out of his nose, which was distressing because we thought, okay, is there a fractured skull? Is he leaking CSF? So we thought, okay, fortunately we had mannitol. We were able to administer mannitol. And then the 2 other men sort of come in and they look well, they look okay. And I'm sort of thinking, what do I do here? Do I just make them wait? But I don't really know what the extent of their illness is just because they look okay. And what I realized eventually was that once we had removed some clothing of the other 2 gentlemen, especially their hats, they had much, much more severe head injuries than the first man. And it just happened to be that the first man was more eager to receive medical attention, that the other 2 were left to wait. And once we realized, we promptly discharged the 18-year-old female from the A&E into the medical ward. The young man who had the first injury was left with his current management, and we promptly had to manage the other 2 gentlemen because they had quite severe head injuries, which could possibly have been fatal if we had just left them or not acknowledged them. And my learning experience from that was to just not take things as they first appear, and also not listen to the person who screams loudest, because actually sometimes those who scream quietest are the most ill. So that's everything I had to speak to you today. I hope that was informative and helpful, and I hope that I didn't run over my 10 minutes too much. If anybody has any questions, please let me know. I'm willing to take any questions with regards to Kisiizi Hospital. I appreciate I didn't talk on the actual structure or the organisation of the hospital too much. Thank you very much.
We all got any questions?
Did they have like those emergency protocols in your?
Yes, they did. So yes, they did. Whether they were followed in practice is another question, much like the NHS, I suppose. So the emergency protocols for things like DKA, asthma attacks, anaphylaxis, snake bite, viral hemorrhagic fever, they were all very clear. But major trauma, less so. I think because often it takes a while to adopt new schemes, new protocols, and whilst major trauma has been around for a long time, I still don't think they quite appreciate it as much as the medical problems. Yeah.
Was the default of the TB and antiretroviral medication because of cost, or just because he thought he was better? Or?
No, so TB and antiretroviral therapy is provided free. Yeah. So that wouldn't have been. Often there's a language or an understanding barrier on why someone has to take their medication. It's the same with here. When someone feels well, why should they take their medication? They will question that, and so yeah, they just stop taking their medication. There's various reasons. Something I didn't touch on is that alcoholism is absolutely rife in especially southwest Uganda, and it really impacts almost every single family, and many men, and that causes a real difficulty in adhering to medication. Yeah.
Are there local, is the staff consist of local doctors as well as people from outside? Or
yeah, I was, so when I arrived, I was the only non-local person there. When we left, there had been one, two, maybe three what they call Mzungu doctors who'd come over, but almost all the doctors were from Uganda, apart from one who was from the Democratic Republic, and there was one who was from Rwanda. Yeah. Yeah.
Outside of hospital, how did you find your time in Uganda?
Yeah, so really enjoyed it. I went with my wife. Kisiizi is a village that runs both a primary school and a hospital. She was working as a primary school teacher whilst we were out there. We really enjoyed our time. The locals were really hospitable, and we had lots of children in our house every day. We brought lots of games and things for them to play, and they really enjoyed learning phonics from my wife, and we really enjoyed it. The one thing that got a bit monotonous was the food, but you know, not everywhere's perfect. So it was a beautiful place. There is this unbelievable waterfall, as you can see here, which the river that falls into that waterfall powers the entire village on hydroelectric power, which is pretty good. It means there's a pretty steady electrical supply to the village